Good afternoon, everyone. I just want to check if someone can confirm that I'm audible.
Yes, Neil.
Okay. Well, good afternoon, everyone. My name is Neil Moran. I'm a specialist in obstetrics and gynecology based at the KZN Department of Health. And it's my pleasure this afternoon to introduce the speaker for the College of Health Sciences webinar. Our speaker today is Professor Tsidi Sebetlwane, who is a specialist obstetrician and gynecologist, trained locally at the University of Natal, as it was then called. She is now the Associate Professor and Academic Head of the Obstetrics and Gynecology Department in the College of Health Sciences at the University of KwaZulu-Natal, South Africa. And she's held that position since 2017. She's currently a member of the College of Obstetrics and Gynecology under the Colleges of Medicine of South Africa and chairs the Part 2 Fellowship Exam Committee for Obstetrics and Gynecology. Her first research focus is maternal health and specifically HIV in maternal and women's health, which is what her PhD was based on. And she's authored many publications on the topic. Internationally, she currently sits on the 2 subcommittees on women's health in the AIDS Clinical Trials Group of the National Institutes for Health in the USA. And she has previously served 2 terms as a member of the Ethical Aspects of Human Reproduction and Women's Health Committee of FIGO, which is the International Federation of Gynecology and Obstetrics. She's also passionate about prevention of cancer of the cervix. In 2018, she spearheaded a massive cervical cancer screening campaign, which set a new world record of more than 2,000 pap smears performed under one roof in a single day on eligible women. She's currently working with the National Department of Health on a pilot project to introduce HPV screening as part of clinical protocols. She currently serves as a member of the WHO Guideline Development Group on screening and treatment for preventing cervical cancer. So let me stop there and hand over to Professor, who's clearly a most suitable speaker to address the subject for today of women's health challenges in changing times. Over to you, Tsidi.
Thank you so much, Dr. Moran, and colleagues. Good afternoon today, being one of the days of the Women's Month in our country. And we thought that this topic was very apt and in time for us to just reflect a little bit on what are the issues in our domain in this month of women. And happy Women's Month to everyone and all the women, in particular, just to say thank you to Professor Ngama and the ladies in the PRO office for giving us this opportunity to focus on this a very important topic in this very important month of women. Just as a start, where are we? Okay, so basically I think with a topic that addresses what the changes have been in women's health. I think at the top of our list and everyone's mind is the issue of the pandemic and how it has affected the issue of women's health. We know that prior to the pandemic, there were already pressures from the socio-political platform, both universally and as well as locally. And the discipline itself has been undergoing some changes over the years. So that in the background, we know also for those of us that are following issues on women's health, that amongst the sustainable development goals that are set by the United Nations to be achieved in the year 2030, that we should all pursue the aim of ensuring that every person has a healthy life and promote well-being for everyone at every stage of their life. With regards to women's health, the focus and the targets are to reduce global maternal mortality rate to less than 70 per 100,000 live births. And concomitant with that is also to pursue the goal of achieving universal access on issues of sexual and reproductive health care, including family planning and many other sexual and reproductive packages that should be integrated into national strategies as well as programs. As a country, we are very privileged that we have very transformative and progressive policies and legislations and documents, all trying to achieve women's empowerment as well as gender equality. And a recent review of these indicators suggests that we are actually on track in trying to achieve improvement of women's health as well as gender equality in our country, obviously with a lot of challenges, but the trajectory is on an upward trend. And on the overall, the quality of women in our country is said to have improved over the years. And just focusing a little bit more on what has been the effect of the pandemic, and those that have gone through other pandemics and evidence from Medicine's Science Frontier says that when you go through a pandemic, the devastating effects of the deaths is things that actually go beyond the disease itself. And the effects of the lockdown go far-reaching into every aspect of our life. And we've seen that with women's health have suffered a lot of secondary effects from this pandemic. And as more services were being redirected into where acute medicine was needed, we found that sexual and reproductive healthcare packages were less and less being prioritized. This was not just within our country or in developed countries. This was seen a whole world over. With regards to the maternal mortality rate, we know that the death of a woman can be very devastating, not just at a personal level for herself and the child, but the effects are very far-reaching to the children that remain, as well as the whole society at large gets into a cycle of deprivation and poverty, which really need concerted efforts for everybody around. It is reported that a woman dies every day. About 830 women die across the world from these preventable causes during pregnancy or childbirth. And therefore it tells us that with all the goals that we may have or set for ourselves in line with the SDG, it may become very unfathomable for us to attain these by the year 2030. It therefore calls that we should have all concerted efforts and put every impetus and drive towards showing influence so that the direction can take a right direction. It's said that South Africa itself is on par and in line or on track to deliver on this mandate of reduction of maternal deaths to below 70 per 100,000 by the year 2030. And it is very encouraging to note that in the past 25 years, where we have started reporting deaths in 1998, far above 150, we managed to reach at least below 100 in the year 2019. Again, bearing testimony to the fact that when we put all our efforts together and focus on a particular mandate and put everything, despite the challenges that we experienced, especially with the maternal deaths in particular, we can begin to shift the needle in the right direction. So this graph again just shows us here where the maternal deaths have been. And you will note that, as I said, we started off around in 1998 in the first reports. Obviously, not all facilities were reporting. And as more and more people were becoming familiar with the process and also noting the effects of HIV around the time when antiretrovirals were not the standard of care. And you will see that by 2009, 2010 and so, we began to really show some reduction. And the game changer here was really the introduction of antiretrovirals into care as routine package of care into women. Initially for women who were pregnant, but obviously as more and more women and evidence showed that everybody needs antiretroviral therapy lifelong. And you can see we managed to sustainably reduce the maternal deaths, which were mainly at that time driven. All other causes have improved, but not significantly as did the HIV as a cause or an influence on maternal deaths. This last report also from Stats South Africa of 21 shows that as a country, as a country, we are in line or on track to achieve maternal deaths below 100, and obviously the target being below 70. The maternal mortality ratio in the facility is also reduced to about 88. And for the first time in 2019, that we were able to get to that level. Then came the pandemic, and we all know that every aspect of our lives was changed. And you can see quarter by quarter on this graph on the right that the maternal mortality rate initially was going down, and we reached below 100 in 2019. But then it began to go up in the first phase of the lockdown and continued to do so with the different waves that we experienced across the country. Just looking back home, closer to the institutions that we work in, yes, as a country, you can see that we were, again, on track to lower our maternal mortality rate. As a province, definitely. But then you look at certain parts, the districts of eThekwini, Ugu, and Ilembe, these are the coastal districts. eThekwini obviously being very much urban, and most people were obviously felt the lockdown impact and therefore not able to access, for care or late presentations, as well as a number of people who may have actually been able to access and therefore die within facilities. Whereas when you look at Ugu and Ilembe, yes, there were some deaths, but because of lack of access to health facilities, it is possible in rural areas that some deaths may not have been in the facility. And this is the in-facility maternal mortality ratio. Perinatal outcomes were similarly affected by the pandemic, and a recent report, systematic review and a meta-analysis of 40 studies. And this was early, just immediately after the introduction of the lockdown in 2019, 2020, showed that there was a significant increase in maternal deaths in stillbirths, as well as mental depression amongst women in countries across the world. And also the in-facility births initially reduced because of the lockdowns, and they further began to increase and access care. In South Africa, the stillbirth rate also increased significantly, even though there might be some discrepancy between the sources of data. With the increase in the stillbirth rate, obviously the perinatal mortality rate also goes up. Fortunately, the early neonatal death rate was reported to be relatively static, noting some increases in certain areas, but on the overall, it was static. The stillbirth rate, once again, in facilities where we work in, remembering that with NAPEMCO, the target is for us to achieve a stillbirth rate of less than 15 for all the births that are above 1,000 kilograms. And here, the stats are not necessarily broken in terms of birth weight, but you can see that we still above what we need to be achieving as a target. As a country, firstly, KZN, and definitely the three districts that I mentioned that are the coastal districts, we're still far above reaching the targeted stillbirth rate of below 15 per 1,000 births. And again, these are over the years of the pandemic, and you can see the increases thereof. With regards to other sexual and reproductive packages, moving away from pregnancy, family planning was also affected. And the United Nations Family Planning Association says that for every 3 months of the lockdown, they estimated that about 2 million women were unable to access their method of choice. And on the average, across the world, women experienced about 3 to 4 months of lockdown, meaning that obviously then you would get up to 7 million of unintended pregnancies. The WHO regional office reports that in South Africa, about 48 and up to 56%, almost half of all the women were unable to access these contraceptives of choice. And it's more important when you look at some of these women may have suffered sexual violence and needed to prevent that pregnancy, and so that it doesn't end up as an unwanted pregnancy and a miscarriage or a termination of pregnancy. When you look at the local stats regarding our tuber ligation services at King George, we actually never recovered from the pre-pandemic numbers, which were around 768. And by 2021 numbers, we were still half. And services therefore need to gear themselves as to how do we then recover back to the norm and begin to improve on an upward trend. With the lack of access of family planning services and also the domestic violence and abuse of children, Gauteng reported a 60% increase in teenage pregnancy, something that is very devastating for everyone even to think about. And importantly so, because a number of these, close to 1,000 of these were below children below the age of 16. And by our country's definitions, that is statutory rape and should actually be reported. And you can see that on this graph, the issue of teenage pregnancy was not just the issue of the pandemic. It's actually been going on and increasing gradually over the years. And therefore, it's an area we need to really pay attention to. So again, just focusing in summary of the things that we've spoken about, access to contraceptives was reduced, teenage pregnancies was on the rise. And though it was reported in Gauteng, I'm sure many other provinces experienced a similar trend. Gender-based violence, again, was an issue. We've mentioned about institutional maternal mortality ratio that was improving. And again, the pandemic took us just backward. So GBV was not just an entity in our country, as seen all over in developed world, mainly because of the frustrating effect of lack of income, people being locked in and unable to either gain income or just faced with each other the whole day. Tensions begin to rise and so forth. So 1 in 5 women experienced the physical abuse by a partner during the pandemic. Again, noting all of that and the pandemic itself making it difficult for people to access the necessary care in terms of preventative PrEP, contraception, and the necessary antiretrovirals if they were already on it. And GBV remains to be a very important topic in our setting because it contributes significantly to maternal deaths as well as poor obstetric outcomes. When you look at TOP services, because of the lockdown, they also suffered a reduction in terms of access and use. And I think one thing that we need to really begin to look at, probably with a retroscope, is what the effects were in terms of whether there were increased miscarriages or septic miscarriages that accessed the health facilities, because there was definitely a reduction in access to termination of pregnancy. When you look at HIV, which remains a central issue within the health of women, they still bear the brunt of the disease. And as you can see on the extreme right of this graph, that about 17% of all the women in our country are HIV infected. Obviously, these are non-pregnant women. When you look at pregnancy, it's about 27%, almost 1 in 3 women are HIV infected. And what is worrying is that the prevalence or incidence continues gradually increasing within the ages that are deemed as reproductive age group. So the more women enter puberty and right up to the 40-year-old, the prevalence of HIV is increasing. And what is said is that with women in our country, most of them who are HIV infected now accessing HEART, we should not be seeing any cases of mother-to-child transmission. But this continues to be a problem within our setting because of the total number of people that maybe are still being infected and new infections that go undetected until women are way into their pregnancy state. What's encouraging is that over the years, the total of the proportion of women that are HIV infected and falling pregnant up to from 60, over the years from 60 to about 7% of them are doing so while already on treatment, meaning that at least pregnancies are covered by antiretrovirals, which regimens have been considered and are safe enough for them to fall pregnant on. But what we know at the clinical interface is that though women may be, who are HIV positive, may be on treatment, a number of them are not as compliant as we wish they were. And there's a large number of them with positive or high viral loads, which still increase the same problem that we're dealing with of lack of significant reduction in mother-to-child transmission. So during the pandemic as well, during March of 2019 and December of 2020, there was a significant reduction in the total number of people that tested for HIV. Again, increasing the number of undetected HIV positive people, and therefore increasing again the risk in many other areas. So HIV remains a very important contributor in many aspects of women's life. Firstly, in maternal mortality, as we previously shown, and with the use of ARVs, we were able to show good progress thereof. But when it comes to cervical cancer, you will see on the bottom graph here that there were some increases in this data is from the local NHLS, and the total number of smears around 2018, 2019 increased, again in line with the campaign that we did. And there were subsequent other pockets of that similar type of campaign. And we managed to sustain that in the years 2019, 2020. And then came the lockdown of 2020, 2021. And we still haven't recovered yet back to at least the bar that was set in the 2018 campaigns. So there's still, again, here an area of need that needs to be attended to. We know that HIV is also very importantly affecting other aspects of women's life, a whole lot of other gynae conditions like pelvic inflammatory disease or ectopics, and all of that needs proper impetus again on HIV and its manifestation. So there's quite a lot of things that we learned in the pandemic, and in terms of the responses that are there, and one of them, and importantly so, is that we need to flag sexual and reproductive health as an essential life-saving part of care. And whenever faced with a crisis, we should not allow that staff be moved from either maternity or SRH services. And this should remain one of the top priorities, which despite whatever challenges as a country or as a nation or internationally, we circumvent as an area of need and priority. The pandemic allowed us to think more innovatively and out of the box in terms of monthly treatments for people, antiretrovirals and contraceptives that could be given in bulk. Obviously, with regards to contraception, it exposed a large need for us to actually move on to lax, long-acting reversible contraceptives. And I think had we really been very forceful in that regard, a large number of our women would not have been found wanting with the unmet need of contraception during the lockdowns. Delivering antenatal care remotely was also embarked on by different settings across the globe. Women being given video calling, using WhatsApps, and a whole lot of other avenues where women, and we in our country are also having a mamas program. And I think it also calls for us that when we have crises like this, we get on to what we already have and see how we can maximize it to the betterment of the health of our women. There's been a lot of databases that were made as a result of the COVID pandemic. And I think that taught us that with more focus and more political will, everything is possible. And, it's a tragedy for us that we only see a woman when she's pregnant, and then we see her again in the next pregnancy. And in between, our family planning doesn't speak to the maternity services and so forth. So I think we've learned a large number of lessons from the tracking of patients and all of that through results, through treatment, through vaccines, that we learned from the pandemic, and we can leverage all of those into the betterment of the women's health package that we give to our women. There was a large number of resources that were mobilized in country and outside the country regarding human capital as well as finances. And again, it goes back to the same thing that I was talking about, that if we put our minds to it, everything is possible. Again, continuing to prioritize the SRH packages as an important aspect of a life-saving care. So we need to really be embracing these technologies. We need to go back and find areas where a large number of rapid tests were developed, laboratories were opened, and see where we can fit in the women's health as well as SRH packages, and make sure that we use these to the betterment of the women and their care. So we mentioned that the pandemic was not the only thing that has been changing within the landscape of SRH or women's health. Obviously, prior to that, every other place around the globe was experiencing a lot of economic meltdown and all of that. We depended a lot in previous years, in the years of HIV epidemic in our country, on the support that we received from other countries outside. But when the pandemic came, everyone was on their own, and we all had to work with what we had. So we really need to see how all those changes that impacted us prior to the pandemic, and much more now, the post-pandemic effects, where we are, and regroup and get better in terms of where we can move forward. Within the discipline, we know that there are subdivisions in women's health, most of which is very much advantageous in that you give focus to where it's needed, whether it's pelvic health, pelvic floor disciplines, whether it's fetal-maternal or oncology. The more time you spend on something, focus on it, the more skill you are able to acquire, the more you get to understand the disease, and the remedies are also developed in line with patient care approaches, patient-centered approaches. So there's quite a lot of advantages we can leverage. But what the pandemic did was to expose all these subdivisions as caveats in our discipline, where you would find that maternity was struggling, stillbirths were increasing, maternal deaths were on the increase, and other aspects, were not necessarily receiving the blunt end of the stick, so to say. And I think it calls to all of us who are working in women's health to see some of the indicators as actually basics for all. And we elaborated on those: women's health in terms of maternal death and access to SRH, as well as cervical cancer prevention. It should really be a goal for all of us, and not to say it's just those working in certain areas. And there are areas where we can devolve right to the lowest level of caregiver in terms of, prevention of cancer of the cervix can be done by nurses, can be done by anyone working clinically trained. Contraception is obviously now beginning also to become a small area of subdivision in reproductive medicine, but it should really belong where it should stay where it belongs, which is in the hands of family planning nurses and stuff like that. Because we as a country really cannot afford to continue to subdivide the discipline such that when the crisis comes, nobody is paying attention, and yet it is supposed to be the problem for all of us and the goal for all of us to achieve these goals in a committed way. So the pandemic, in conclusion, has allowed us to identify areas of concern within the discipline, within women's health, and also identify the gaps where they exist, show us that we were able to work with what we had for a while. And really that should be the goal, that we should not wait for someone to come and salvage us. We need to really say, where are we and where were we before the pandemic? What were the gains that we made? And where are we right now? And what can we actually salvage? And how do we then move forward with what we have? Listening on the radio this morning, somebody was cautioning that we should be less on data and more on intuition. And I think that's what the pandemic also showed, that, we can continue, even just from the talk I've just given, to pay so much attention on data, on who said what, who documented what, But what remains is what actually have we done and what actually can we do? What do we know works? And we have proven that it can be used going forward. And I think that should be our approach. Thank you very much. Back to you, Dr. Moren.
Thank you very much, Professor, for a concise talk on current women's health issues, particularly following the pandemic. I think you covered a lot of ground, touching on a lot of different topics. Can I just say to everyone that if anyone has comments or questions, please write them down on the Q&A section on the Zoom, and then we can discuss those questions with the whole webinar. So far, we've got one question. So let me put that to you, Tidi. This is a question from an anonymous person, but it's somebody who's studying law, LLM, and is doing a dissertation about menstrual leave. So she would like to, or he or she would like to know your view on how women's menstrual health impacts women's overall health. And what do you think South Africa could do to improve women's menstrual health and hygiene?
Thanks, Dr. Moren, and thank you to the anonymous attendee for this question. I think firstly, we need to identify that menstruation is actually a physiological process, just like pregnancy is. And a large number of women would experience this on a monthly basis throughout our reproductive. In actual fact, we spend the better part of our lives from 15, say 45, that's a good 30 years every 12 months undergoing menstruation. The unfair part of it is that it comes sometimes with discomfort, and a woman has to present to her place of work or a place of where she is needed, despite the discomfort, which can be looked at in terms of the degree thereof. It could be pain, but there's also what is called a premenstrual psychotic mood disorder, which obviously that needs special attention. And therefore, in that whole phase, we need to identify what is normal and what is not normal. And obviously, what is not normal then gets onto being a disease spectrum, and that obviously can be treated with medication. And women afforded the medical or sick leave that may have impacted on her life. Obviously, all of that translates into the overall output and financial abilities of women. So we cannot downplay that. There is a move right now as to whether we should, seeing that this is a natural process that has been placed upon us as women to have this menstruation throughout the whole better part of our 30 years, whether the government should assist women, in particular regarding menstrual products, pads and so forth. And there's a large drive, which the better part of my understanding says that pads are being provided for at schools. I haven't really applied my mind in terms of what program that is coming out of, or whether it is once off, but a large number of schools are accessing menstrual health packages through the government assistance and other NGOs, particularly NGOs. As to whether it should become mandatory, I would support that. I think really it's something that can be very embarrassing, especially for the young girls who may not have proper products, and that can affect their health and hygiene in the long term. Yeah, I hope that answers your question.
Thank you very much. Let's see if there's any other questions. Maybe I can just come in with one. Sidi, you, amongst your main areas of focus, one of them was planned and successful pregnancies. And you did mention in your talk that we seem to have increasing numbers of teenage pregnancies, even younger teenagers. Now that is not a new problem that has recently been highlighted because of the pandemic. It was actually there all along, as you mentioned. And there have been quite a lot of interventions that have been discussed, or there have been attempts to implement them to improve that situation and reduce the teenage pregnancies. But so far, nothing seems to have worked. Do you have any suggestions about any new strategies that we should be using to address this really major problem of teenage pregnancies? I think I can just say, maybe when we were starting in our training, more of a problem was the grand multiparous, women who had 9, 10 pregnancies and so on. They were a big problem. We're not really seeing that anymore, but every day we're seeing young teenagers pregnant. So I don't know if you've got any comments about what we should actually be doing about that.
Thank you so much, Dr. Moran. It really is a problem. And I think it's time that we take it up with the same energy that we are taking up many other issues. I'm not downplaying gender-based violence, but in the recent years, it's receiving enough, or at least some attention that it didn't before. And even at the community level, people are beginning to note GBV as a problem and reporting and accessing the help they need. And I think if we could, with the same voice, and if not more, begin to speak on teenage pregnancies, as you say, are definitely on the rise. The devastating effects are long-term. Once you are a mother at the age of 15, and what we also showed in one study in Umlazi, that you find amongst teenage pregnancies, about 20%, 18% in that study were repeat pregnancies within teenagers. So when you have a teenager at the age of 19, in her second or third pregnancy, and the painful part is when they deliver through a C-section, and you know, by the time somebody is 20, long before they are even thinking of getting settled, they have a scarred uterus and all of the many other effects that we see. So your question again, what should be done? Teenage pregnancy is a multifaceted problem. It's not the problem of health alone, because women or young girls fall pregnant out there in the community. What is it in the community that is driving teenage pregnancies? One is the things that we feed them. When you show young girls that a pregnancy is well accepted, and I'm not saying we shouldn't support our teenagers, but when it's so accepted and all of a sudden it becomes granny's little baby and everybody's, you know, it's like a normal thing. And then the girl goes back to school, comes back with a second pregnancy and so forth. And the things we feed them on television. So you find that young girls are exposed to all our celebrities that are getting babies out of wedlock and all. So all the many, and I don't want to really, you know, cast aspersion on anything in particular, but it is incremental things, small little things that build up to a young girl to say, actually falling pregnant is not such a bad thing. And she sees her colleague at school coming in, and yes, we say that they must go back to school in uniform and still deliver up to, you know, go to school up to 9 months. All of those says, you know, there's nothing wrong. And until we really say that, but there is something wrong, you know, it's not quite a good, it's not, we shouldn't just make it's wrong and stigmatize it. It's wrong in the effects that it has. And that's where we need to start. And then, as I said, it's multifaceted. We need to go back to school-based programs. We need to go to all the things that I'm saying we are feeding the young children. And then comes the gender-based violence and all the other systems that come in. So until we really apply a comprehensive approach, and then for us in women's health, the issue of lacks, fine, a young girl has made a mistake at the age of 14, 15, and maybe 16. We need to make sure that we send her out on a method that is going to allow her to, you know, go and finish school. So we really should be promoting more Implanon IUCDs in young girls, because me and you will attest to the fact that, yes, we discharge them on depot and Aristorate, and 2 years later, they're back with us with another baby, because they don't have time to go to the clinic to be accessing this 2-monthly, 3-monthly type of contraceptive. We need to be discharging women with something that is longer and that will buy them time to finish school. So I think it really needs us to apply our minds and be very focused when it comes to teenage pregnancy. But a large number of other disciplines and the DSD, Department of Social Development, everybody needs to come on board. And the messages we send to the community are very, very important. I hope I answered your question.
Yes, thanks, Prof. I think along the same lines, we got some input from Piwe, Nota. She's saying, in my own work, I'm not quite sure what that work is, I have seen that schools are significant platforms in identifying vulnerable adolescent girls and young women living with HIV, and also, she's also brought up the unintended pregnancies as well. And it's a platform where they could be linked to services that they need. So school-going adolescents spend most of their time in school rather than anywhere else, which makes schools the ideal platforms for reaching this vulnerable population group. So do you have any comments about actually using the school as a platform for addressing these issues, and in what way? Can we bring contraception to the schools? And Piwe has also asked a question. Are you able to share your slides with the participants? And are you open to further engaging after the meeting offline?
I'll start with the last one. Yes, I will share the slides. I have not referenced them up till now, so which is very important. I will do that once I've referenced appropriately. And engaging offline, that's fine through Lisha. I'm sure Piwe will be able to get the details from the PRO's office. With regards to using the schools as a port of entry for us to reach the young girls, I think we should use every platform we can. I know that the schools have what they call that program, social, whatever, where they are taught sex and all of that. But we should also
life orientation.
Life orientation, thank you. They score very well on that one. When you look at their metric results, LO is always on top. So, but we need to make sure that LO, makes a difference and it counts. Not just about having sex and showing, the more we expose, I don't know what goes in. We don't have to tell children how to have sex and show them, penises and vaginas and stuff like that. We are stimulating the mind. I think it should be more a preventative type of sexual education that they receive. Show them, obviously, what we should start with the ABCs. And I think right now where we are, we've given up on abstinence. We've given up on encouraging young girls, and we think that, okay, the B and the C's are the only ways. We need to continue to promote abstinence in the young girl. We're looking here at women's health, and cervical cancer has got everything to do with somebody's sexual behavior. The earlier you start, the young girl is exposed to the HPV, and later in life, she's exposed to cervical cancer. So those are the type of messages we should be teaching at school, that don't start early, you are too vulnerable, the abstinence type of message. Then we come to be faithful. Again, how many of our young girls, we know that she may be looking at this one guy, but the guy is looking at 3 or 4 other girls elsewhere. So the be faithful we need to promote, but within the context. And then comes the C's, the contraception, the condoms, and all of that. And I think many of us are no longer talking the ABCs because we think that it was all to do with HIV, and yet it is a package that we should apply across, especially when it comes to diseases related to HIV and STIs and unwanted pregnancies. Yeah, I think, school can still be used. I'm just worried about the messaging that is going on there. The more we tell young people that, yes, you can have sex this way, and you have, we demonstrate condoms and we don't preach abstinence. And people have ridiculed abstinence, by the way, to say, do you think they will? Out of the many, if the more girls feel that they are abstaining and there is a support group, and there's a large number of uptake on other girls who are not having sex, the more they will embrace it, and the more uptake there will be on that platform. Yeah. Is there any other?
I don't see any more in the question and answers, but I just wanted to move on to the HIV issues. This week, I heard about 2 women who had unfortunately died during pregnancy, in other words, maternal deaths. And in both cases, these deaths were due to disseminated TB. And one of them had booked for antenatal care. Her CD4 count was 9. And the other one, the CD4 count was 36. So both of these women were multi-parous women who had had previous babies within the last 3 or 4 years. So during the time of ARVs and so on, but now obviously they were not on ARVs and they were severely immunocompromised. So are we seeing this now that we are, because I hadn't seen those kind of cases for a year or 2, you know, do you think we're going back to a situation where we're going to have larger numbers of severely immunocompromised women with HIV because of treatment failure or not having access to treatment, maybe following the pandemic? Is that something that others have seen as well?
Thanks, Neil. Yeah, I think that pandemic did report that there were quite, firstly, I noted in the slides that there was the total number of testing reduced, and we understand because women were not accessing health. Of the ones that were coming forward, that South Africa was saying that there was an increase in those who are HIV positive, women living with HIV who were now on HAT. And I did mention in my talk that what we see is that most of them may be on HAT, but they're not compliant, or else, you know, as you rightly say, they're coming in with very high viral loads, very low CD4 counts. So I think we are going as a result of either the pandemic or people just fatigue of antiretrovirals. And I think that's where the science needs to move in terms of, you know, injectable forms of antiretrovirals or whatever other form we can access, because definitely there were significant gains when we began to implement HAT for all women and for everybody who is HIV infected. But we need to find newer strategies and newer messages, because either there's fatigue in treatment or people are just thinking, because I'm not pregnant, I can default. And it's not just in pregnancy. Maybe we pick it up in pregnancy. I've had people who you clearly can see this deterioration in health. Not that they didn't know they were HIV infected, but somehow the stigma remains, I think. The stigma of HIV remains even many years beyond what we think we have conquered. We're still almost where we were. So yeah, I think we in the midst of all of this, we shouldn't forget that HIV is a highly preventable disease and highly treatable disease, but there are still a large number of women that are struggling to adhere to treatment for various reasons.
Thank you. We've got a hand raised by Nonsikelelo Zondi. Do you have an oral question? Please go ahead.
Are they able to talk or they are muted?
I'm not sure about that.
I think they were only allowed to type the message.
She just needs to unmute. I've allowed her to talk.
Oh, okay, sure.
Nancy Kalelo, your mute button is still on.
Is she coming through?
Not yet, but there's another hand raised by Ursula Wessel.
Okay.
Go ahead.
Ursula, go ahead.
She doesn't. She's muted, but we can't hear her.
It looks like people are not able to speak. Please try to type your questions on the Q&A, and I will relay them. In the meanwhile, maybe they'll type their questions just now. Just one last one from me, Professor. What is your take on how we should attend to foreigners who come to our health facilities pregnant and seeking care during pregnancy or labor? Because that seems to be a topical issue.
Why are you becoming a politician now, Dr. Moren?
No, it's a clinical question.
We know that the MEC for Health in Limpopo is in hot soup. I think really the issues are real, and the anger of the community is real. We have no ground to deny treatment to anyone, particularly in pregnancy, to all women who need help. And I would go on to say to anyone who need acute help. I think what the MEC, what we saw her say, and in that video clip was quite unfortunate in that she's faced with realities on a daily basis. But then we have a country that has got very good policies that are right for all of us, but then they don't address our day-to-day experiences. So the long and short of my answer is that yes, we cannot turn women away, documented or undocumented, particularly in pregnancy. It's something else when you're talking about elective gynae care and stuff like that. But SRH, as we mentioned, is a life-saving procedure and package. We should, in our domain, it's not something that we can easily say we will not attend to anyone who needs our help in the women's health domain. But I think on the whole, as the minister, deputy minister said, Dr. Dlomo, she was correct in what she said, but probably not in the right platform, not in the right way, I think. It needs, again, a concerted group of people to address those issues that are plaguing us. It is true, a lot of our facilities are overwhelmed. And it's not a place for us, me and you, to begin to say, look for IDs and whether you've got a passport or whatever it is that brings you into the country. It's not our place.
Thank you for that. We're not getting those questions through from Nonsikelelo or Ursula on the Q&A. I'm sorry if the system is not allowing you to speak. I think we've almost come to the end of the hour. Are there any last words you want to say before we close, Professor?
No, just to thank the audience and again to thank the PRO's office and the DVC for allowing us to present this in the month of women celebration. We need to really continue to look at all these indicators with a very close eye. And as I mentioned before, that there are basics that belong to everyone who's in the women's health domain, and we cannot devolve the discipline to the point where when a crisis arises, then it is somebody else's business and not somebody else's. It's all of us. And if we approach it that way, we will, I think, win. Yeah, thanks.
Thank you very much, Professor Sebekluane, for a very important talk, as you say, in the month of Women's Month. You've covered a lot of important topics: maternal mortality, the effect of the pandemic, HIV, gender-based violence, family planning, sexual and reproductive health gaps, including cervical cancer. So it just remains for me to, on behalf of all the participants, all the audience, to thank you for your time and the time you spent preparing the slides. We understand that you'll just edit them and then make them available for those who would like to have them. So thank you very much again, and to the university for organizing this important session. I think we'll close there. Thank you.
Thank you so much to you, Dr. Moran, for sharing. Thanks.
Pleasure.